Good morning. My name is Paul Perlman, and I'm a program director at the NCI Center for Global Health. Thank you for joining us today for our Global Cancer Research and Control Seminar Series. This seminar series features talks by researchers and cancer control experts working in global oncology and provides opportunities for discussion and collaboration on impactful and innovative work addressing cancer morbidity and mortality worldwide. I'm delighted to welcome Dr. Nimmi Ramanujam to the center this morning. Dr. Ramanujam is the Robert W. Carr Jr. Distinguished Professor of Biomedical Engineering and a Professor of Cancer Pharmacology and Global Health at Duke University. Additionally, Dr. Ramanujam is the Director of the Duke Center for Global Women's Health Technologies, which she founded to catalyze impactful research and educational and community outreach activities that promote women's health. She has been widely recognized for creating globally accessible technologies for women's health related to cancer screening, diagnosis, and treatment. In 2023, at the 45th International Conference of the IEEE Engineering and Medicine and Biology Society, Dr. Ramanujam was awarded the IEEE Biomedical Engineering Award, given annually for outstanding contributions to the field of biomedical engineering. Nimmi likewise gave a stellar plenary at that very meeting. Dr. Ramanujam also created the Kala Health Foundation to commercialize her technologies, in addition to a number of other initiatives and consortia, including WISH, Invisible Organ, and Ignite, that have far-reaching impact on cervical cancer, reproductive health, and engineering design education. As if this wasn't enough, I feel obligated to plug Nimmi's fantastic new textbook, Biomedical Engineering for Global Health, Cancer, Inequity, and Technology, which she co-authored with her colleague from Duke, Brian Crouch, and I can personally vouch for. Today's seminar will examine the intersection between the global burden of cancer, health inequities, and technology innovation. Using cervical cancer as a case study, Dr. Ramanujam will discuss how new biomedical engineering solutions can extend the reach of high-quality cancer prevention and control services to a more diverse population and explain how these innovations can be disseminated for broad impact. Before handing the session over to our esteemed speaker, I'd like to review a few logistics. First, please save your questions for the designated Q&A time immediately following the presentation. You may type your question in the chat box or use the raise hand feature. Second, please note that today's presentation is being recorded and will be available on our events website under the Past Webinars tab. Finally, we are now offering CME credits for this seminar series. I will provide additional information on how to claim these credits for today's session at the end of the presentation. As a disclaimer, please note that the views expressed in the following presentation are those of the speaker and do not necessarily reflect those of the National Cancer Institute, the National Institutes of Health, the Department of Health and Human Services, or the United States government. And now we'll begin our presentation. Welcome, Dr. Ramanujam.
Thank you, Paul. Well, I'd like to begin by thanking Satish Gopal and Paul Perlman for giving me the opportunity to speak here today. And I'll get right into it. We've been working for over a decade on technologies for cervical cancer prevention, and we've learned a lot on the way. And that's really what I'd like to share today, both, what has been done, what we've been successful at, and also what the opportunities are to continue to improve the efficiency and accessibility of cervical cancer prevention programs. I'll just take a minute to show this disclosure slide. So I'd like to begin with two women who died of cervical cancer in their 30s, and they lived in vastly different environments and were of very different socioeconomic status. But they both died in their 30s of cervical cancer, which was considered a fairly deadly disease in the 1950s. Henrietta Lacks and Eva Perón had advanced cervical cancer and then succumbed to the disease. But today there are well-established cervical cancer prevention programs in industrialized countries for the most part. And these programs are organized so that you can basically go through a screening step, which is pap smear and HPV testing. And if the screen is positive, then a diagnostic exam with a colposcope followed by biopsy. And if positive for treatment, then the patient undergoes essentially an electric excision to remove the precancerous area. So it's interesting that on the left, we see the impact of these uh, organized programs in the US, for example, where we've seen a dramatic decrease in the incidence of early stage and late stage cervical cancer with increased screening. But the right side basically shows that the coverage depends on the global wealth decile, that basically the richest countries have the highest coverage in screening. And so that is where the gap lies, and that's where also the opportunity lies for innovation. So why is it that there's this big gap? There are probably multiple factors, but two factors that I'd like to share is the health worker shortage. You can see here that the DALYs per thousand um, decreases increases as we see a shortage in the health workforce. And on the right, we can see that as the distance to hospitals increase in low and middle income countries compared to high income countries. And so both of these contribute to structural and human resource barriers that can negatively impact access to cancer prevention programs as a whole. So the good news with cervical cancer prevention is the fact that there have been great innovations, point of care innovations that can bring screening and treatment solutions to the point of care, including on the left, self HPV testing, and on the right, thermal ablation for superficial lesions. But one area that's recognized as important to develop and implement is triage strategies so that we can basically streamline the process because only a fraction of HPV positive women actually have treatable disease. So our efforts to do this have been through the development of a portable imaging technology called a pocket colposcope, which was designed with the standard colposcope in mind to basically align with the features and technical specifications of a standard colposcope. And in addition, to facilitate communication and timely decision making, we basically have an app that allows for image capture, communication, and telemedicine. And what we want to do with these technologies is basically see if we can shift from an older paradigm where you have long distances and multiple visits, which can reduce accessibility and make healthcare out of reach, to a new paradigm where you can shift the majority of care to the community level and primary healthcare clinics. And so we need the technologies to do this. We have self HPV testing, we have the thermal ablation techniques, and how can we now introduce triage and integrate this and find a way to redesign health systems that can achieve this goal? So we work in two countries, and in Peru, we're really focusing on implementation and scale up of current mature technologies that we and others have. And in Kenya, we're working on evaluating new technologies as well as continuing to implement and scale the current technologies for cervical cancer prevention. So I'll talk about each of these today. So just to create a framework, um, our goal is to use a systems-based approach to address cervical cancer prevention. And we have four distinct areas that we work in. One is to develop point-of-care technologies and decision-making tools, but also to work closely and collaborate closely with community partners to facilitate implementation uptake of these solutions, as well as create channels for telemedicine health so that you can actually get timely responses for patient care. And the goal here is to mitigate barriers related to travel time and healthcare worker shortage, and ultimately to promote health systems to become more people-centered. And Technologies can catalyze this by empowering communities and improving the proficiency of the workforce with respect to services related to cervical cancer prevention, and importantly, the integration and continuity of care. So, what I'd like to talk about first is community based participation and implementation and telemedicine and mHealth as a way to um, scale up cervical cancer prevention in Peru. So in 2018, we were funded by the USAID DIV program to carry out pilot scale of the Pocket Colposcope and mobile app in Peru. And we collaborated with Dr. Patty Garcia at the University of Cayetano, and she has a community-based program providing critical healthcare resources for women in Peru, and she's also um, has a direct impact through her programs on the reduction of cervical cancer burden in Peru. And so we as a technology group and her group basically conducting the implementation provided the type of synergy that we needed to carry out this program. Dr. Garcia spent a lot of time thinking about where to implement this program, and we essentially decided to launch it in Cajamarca, Peru, where there's not only a high incidence of disease, but the landscape is such that it's very hard for people to get to clinics or hospitals, and there's really only one hospital in that community. So she wanted to go to a place where there was a big gap in access to care, particularly with respect to the access to clinics and the workforce that's needed to carry out the program. So the services that were implemented by midwives and community health workers were performed at home and community centers as well as primary level healthcare centers. So the idea was that you would start with self HPV testing through community health worker promotion of HPV testing. Then what would happen is the women who basically conducted the self-test would drop off the samples at a kiosk at the community clinic. And then we would use a mobile app to schedule an appointment, and the patient would come in for a exam with the pocket colposcope. And then through telemedicine, they would be guided on decision making. And then basically they would use the pocket colposcope for imaging. And then if needed, patients who need treatment would undergo thermocoagulation. And if they had cancer or suspected to have cancer, they would then be referred to a tertiary setting. And we had launched this program in 4 clinics within Cajamarca. So in steady state, this is what the workflow looks like. Basically, the patient comes in, there is imaging with the pocket colposcope, all of the data gets uploaded onto a web server with patient information and images that providers can sort through. They basically look at these images either as a collective group or an individual and provide a guidance on patient management, and then the midwife performs the treatment if necessary or refers them to a referral setting. So this grant started before COVID, but we were at a standstill during that period. And so we were able to really start the program in 2022, and we had to accelerate because the program was ending within a year. So we basically, and this is something Dr. Garcia led, and we worked with her to make sure this was feasible, was that she created the stepwise training plan that really brought all of the stakeholders together. She first had a webinar about cervical cancer prevention that was provided by MD Anderson Cancer Center. Then there was the train the trainer model. And then there were training of health workers in the community setting, a workshop for physicians and midwives, and then training at the second level to provide more specialized treatment, and then training at the third level for more expert specialized treatment. So this continuum of care was very important to her. And so she wanted to make sure that this technology and app could really facilitate this continuum of care. And one of the things with any kind of imaging device is you can document the state of the cervix at any given time. So it also allows for patient management across these different facilities and look at the care outcomes and whether the patient actually completed the care journey. And so the program started in Cajamarca, and now in collaboration with the regional government, it's being extended to other areas in the province. So the pilot scale resulted in a total of 4,000 women, 4,000 plus women who self-collected their HPV samples. About 15% of them were HPV positive. Most of them were able to make it to the primary health clinic. 78% completed treatment, and then 19% were referred outside of the community clinics. And this is fortuitous because Peru launched the policy for the use of HPV self-sampling in 2017, though procurement and distributions of tests started in 2024. And by virtue of having this in place, it becomes much easier to sustain the use of the diagnostic and treatment technologies at these local community centers. So today, this is where we are. So we have the regional hospital that provides LEAP and surgery. We've established Dr. Garcia has established 5 primary healthcare facilities where midwives basically perform the diagnostic and treatment procedures for most of the patients. And then to start expanding to satellite sites, some of these, the initial screening tests are being expanded so that we can essentially have more of these HPV positive patients seen at these 5 clinics. So that's the story in Peru. And our efforts really focused on seeing if we could successfully launch a technology-enabled program in a clinical desert in Peru and work with a community champion, Patty Garcia, who could really have the political capital to be able to get things in motion. And we were really fortunate to be able to do that. But then, as you do these studies or these implementation trials, you start to see where gaps are. And one big gap that we noticed was decision making. And reliable decision making can be impacted by a number of factors. And in these environments, it includes shortage of providers, resources and expertise needed to train providers. We found that with telemedicine, it was great, but there was intermittent internet access. And so other measures had to be used, and it was very stressful in the clinics when that happened. So how could we get to a place where we can streamline and make this process more efficient so that everything else works well that we have already established? So this is where our work in Kenya begins. We are both implementing our current technologies, but also evaluating new technologies in Kenya, and in particular, focusing on decision-making tools. So we established an NCI-funded program, the UO1 mechanism, to develop diagnostic algorithms for cervical cancer detection. And this is a collaboration with our partners who work in Kenya, with an expert in AI at Purdue University and myself. So I want to start by underscoring the need for decision making. This is a very busy slide, but if you look to the right, that basically shows you the gist of the study design. So we conducted an RCT in Kenya where we enrolled HPV positive and HIV positive women in either a pocket arm or a standard VIA arm with comparable number of patients. And what we found was that the sensitivity and specificity of the pocket arm wasn't significantly better than that of the VIA arm, which can be due to a number of factors. But what we did notice is that the positive predictive value was higher for the pocket arm versus the VIA arm. So we did subsequent studies and noticed that obviously these numbers varied a lot, depending on providers, depending on you know, the number of providers, the training of providers. And so this underscores the need for some consistency. And so we use this sort of as a baseline to say, how can we begin to uh, create decision-making schemes that can be more reliable and consistent. So this brings me to our work in convolutional neural networks. And there are some groups that have just done some outstanding work, including Jayshree Kramer and Mark Schiffman, who have published on the use of uh, multiple types of images from multiple devices as a large training set and using non-inference learning to basically generalize to new devices. And these papers have really guided our approach to solving this problem. But we have a slightly different issue, which is the general problem is that there's low prevalence of disease, and this is true across the board. So if you ask what's the big issue, is that with any emerging technology, anything new, a point of care technology you put in place, you're basically dealing with sparse data and you have to find a way to get around it. So the approach that's been used is to combine images from multiple technologies to enrich the number of positive cases. But in the absence of doing that, you risk overtraining, as shown in the red, where the blue, the test data, does not overlap with the training data. So that's the challenge. And it's not a one size fits all problem. It has to do with the data set you have, the technology you have, et cetera. So there's a lot of variables you have to think about. So we need to think about how to develop deep learning algorithms for our application. And so that's what I'll talk about today. So our approach is to essentially do domain transfer, which is to say that our goal is to transfer knowledge from images from a standard colposcope to the pocket colposcope. There are a couple of reasons we took this domain transfer approach. If you look at the images on the right for both the standard of care and pocket images, you can see that even though the pocket colposcope was designed to have very similar specifications to the standard colposcope, there are color differences, et cetera, that can really make it difficult to use images from a different device to train an algorithm and test on a new device. So we needed to find a way to basically create synthesized pocket images. And why did we need to do this? Because we didn't have that large repository of data that we needed with standard of care colposcope images, and we needed to find a creative way to address that data set gap. So this, we believe, is a cost-effective approach to solving this problem, because in reality, to be able to get positive samples, you have to really screen hundreds and thousands of patients to be able to get a sufficient sample size. So how do you address that through alternate approaches that could be more cost-effective? So the way we approach this is we took standard of care colposcopy images and we pre-trained a classifier, a standard architecture such as ResNet or a vision transformer model. Then what we did is we basically said, okay, let's use a generative model to synthesize pocket colposcope images, and in particular, positive examples, so that we can enrich the positive cases in the pocket data set. And then once we had this pre-trained classification model, we then fine-tuned it using the combination of the synthesized and original pocket colposcope data. And on the right, you can see as an example what the synthesized images look like from the original SOC images. And one important thing to notice is that it basically accounts for that color mismatch that we saw on the previous slide. It's able to sort of recapitulate that different color that you see in the pocket colposcopy images. So This summarizes what we have done so far. So on the far left, what you see is a U map that basically shows in green the original standard of care images. On the right, the original pocket images, and then basically in blue, the synthesized pocket images. Actually, it's the other way around. The original is in blue and the synthetic is in the purple. Now, in the bottom, what that essentially translates to is the enrichment of positive pocket images. So you can see that with standard of care, we have 16% of cases that are positive. With the pocket colposcope, we have 21.6%, but the class balance is really off. It's very imbalanced. By adding synthesized images, we address an important issue, which is class balance. So now we have comparable numbers of negative and positive cases in the training data set. So when we developed our algorithm and tested it on an internal test set, we found that basically the AUC improved significantly when you did the pocket image augmentation before implementing the fine tuning, with an AUC of 0.73. And this is actually comparable to the numbers that have been reported in the literature from other papers that are looking at cervical cancer detection using CNNs. On the left is the repeatability of the data. And you can see that if you look at an image 1, image 2 score from the same patient, you essentially get a really high concordance with a Pearson correlation coefficient of 0.951. And then so our data set was made up of images from 6 countries. So what we did to basically test an independent data set is a separate clinical site. So we said, what would happen if we use the same technology, but in a different clinical site? Because we had already addressed the device to device knowledge transfer. And as you can see that when an independent clinical site was tested, we were able to really maintain the performance of the algorithm. One thing that I think the deep learning community is talking a lot about is image quality. You're only as good as the image you put in, and we noticed that in the field as well, which is that blur is a significant problem, and more importantly, it's inconsistent. It depends on the provider, the training, the device, the patient, and so what we did first is before we can address the problem, we need to know how to detect it. So we developed an algorithm that basically does 2 things. It does a pseudo labeling with an FFT, fast Fourier transform, and then trains that using actual images to create a threshold. Then that creates the labels of blur or not blur, and then we use a YOLO algorithm to basically then prospectively determine if an image is blurry or not blurry. On the right, you can see the results of an expert colposcopist lesion determination and the number of image samples that are blurry or clear. And you can clearly see that the clarity of the image does affect the lesion determination confidence. So when we went back to our algorithm and used the blur algorithm on our test data set, albeit small, we found that when we removed the blurry images from the entire test set, our AUC went from 0.73 to 0.77. And of course, we need to validate this on a larger data set, but it points to us that we need to sort of deal with this upfront and make sure that the training is in place to continue to improve the image quality at the point of care. In other words, we really need to connect the provider to the developer and have that data journey be seamless. So that has impacted our work in Kenya, where we have now gone back to a protocol that really tries to address this image quality issue that we have seen. And it involves sort of a daily review, a weekly review, a monthly review, and any algorithm that can automate this process, such as a blur detection algorithm, can also serve as a feedback loop that helps the providers essentially learn from their own images and continue to improve. And so in Kenya, when we started on the first exam, there was a lot of variability and very few patients with a clear image. And this is not the device, right? Because the device has a certain technical specification. It is many other factors. And that is evident when you see that when you have the blur feedback in place, you do see a substantial improvement in the performance of the provider. So this is both as a way to capture good images, but also to help providers become more proficient in using the technology. So the last part of my talk is about addressing yet another, or actually continuing to think of new opportunities for innovation. So we might have a program that's in place at the community level. There might be decision making with telemedicine, and then hopefully in the future, decision making through AI algorithms can serve as a second virtual reader or the reader, the primary reader. But what else can we do to improve access to and make the exam more efficient? So I want to specifically talk about the challenges with the triage exam. So when an exam is performed, there are multiple steps, right, that can lead to interoperator variation. Positioning of the speculum, the timing of when you image after the application of the contrast agent acetic acid, and then, of course, imaging the cervix, and that's going to vary in the hands of different people. There's, of course, discomfort with the speculum that patients experience. And in a place like Cajamarca, even though in our sort of funded program, we were able to get 97% of the patients to come in to the clinic, in reality, if you have a desert landscape, it's very hard for people to come to those communities. So we need to continue to think of ways to transfer or shift care to the home to the extent possible. And so these are the 3 points that made us think about how can we further innovate on technologies to make this a reality. And so we basically upgraded the pocket colposcope to operate without a speculum. Now, the coloscope is essentially has the same engine as the pocket colposcope, but it has a different type of speculum. It has a speculum that is shaped like a calla lily. And what that allows the provider or the patient to do is easily insert and manipulate so that the tip, the S-tape tip of the calla lily can essentially nudge the cervix into place. And we have tried it both ways, and I wanted to share some results with you. So the key features of the coloscope is not just the camera, but as I mentioned, that S-shaped tip that is critical to basically taking a tilted cervix and nudging it into place, and which is what the speculum does with the duckbill, and an atomizer that essentially sprays while the device is in place. So you essentially have the cervix in place, and you capture the entire dynamics from spraying the acetic acid all the way to the end of the exam. First, in terms of image quality, the top row shows coloscope images pre-acetic acid, post-acetic acid, and post-Lugol's, and the bottom shows the colposcope images, the standard colposcope images, and we're able to recapitulate what is seen on standard colposcopy. And the camera is very similar to that of the pocket colposcope, so we would have expected that to be the case. Now, what this technology also allows you to do, whether you do it with the speculum or without the speculum, as I mentioned, is to provide dynamic contrast. And before I show you the video, I want to point to 2 areas. So you'll see that there's enhancement here over time and enhancement here over time. This is the columnar epithelium. But what you'll see is this starts to fade and goes back to normal, whereas this continues to enhance. And that's the advantage of being able to dynamic imaging without removing the imaging device. And as I start the video, you'll see the spray from the atomizer of the acetic acid, and then you'll see what happens. So you can see this area that's getting white, and this as well, this area. And then over time, you start to see this fade, but this continues to persist. And then here is the speculum-free example, and this is a fairly recessed cervix. So you'll see initially that it's hard to see the cervix, but then it'll start to emerge. And so this is speculum-free. You see the acetic acid spray, and then the caloscope is being manipulated to essentially sort of help the cervix pop out into place. And you can start to see that area at 6 o'clock basically turn aceto white. So we're trying to take advantage of this dynamic contrast in addition to the other enabling features to basically improve the information or enhance the information that we can give our deep learning algorithms. So on the left, you can see the difference in the area, the region of interest that's in the where the biopsy was taken, when you have just the final RGB image versus the percent change in intensity in biopsy and normal regions. And so by having just that baseline and end image, you're already seeing a big contrast, but there's the opportunity to basically do segmentation with the dynamic contrast that you can get from these coloscope videos. So I want to conclude by sort of bringing this all together and our vision for integrating these innovations moving forward. So if we think about the general population of, say, 100,000 women, when we do screening with HPV testing, we're essentially reducing the percentage of the population that needs a triage exam. Now, if we could do a first level triage in a community center or a woman's home, whether it's community worker assisted or otherwise, there's an opportunity to further reduce the number of people that need to come to a clinic visit. So the idea being that you could really have broader accessibility for cervical cancer prevention. And so this would really be an integration of self-HPV testing, the coloscope, whether it's used in a clinic or it's used in the home. And then in the diagnostic setting, you would have essentially the pocket colposcope and the thermocoagulator. And you would obviously have the app coordinating all of this, and the decision-making algorithms guide, for example, with segmentation, a decision of go, no go with the coloscope, but ultimately making a decision on how to treat at the clinic level. So that's the vision, and that's how we see these technologies coming together to address this, challenge of cervical cancer prevention. I'd like to acknowledge collaborators and students at Duke, at Purdue, and at Cayetano University, and also at Kemery, and then Mark Schiffman for sharing the colposcopy database, which has been instrumental in helping us create our generative algorithms for the pocket colposcope. All right. Thank you. And I apologize for the glitch, but
Great. Thank you so much, Dr. Ramanujam, for an absolutely terrific presentation. We're now opening the session for questions. We invite you to turn on your cameras if you're comfortable so that we can see each other during this discussion. As a reminder, you can type your questions into the chat box or just use the raise hand feature and wait to be called on. When called on, please unmute yourself and ask your question. And we're going to try to get to as many questions as we can in the remaining time. So. Don't see any quite yet. Okay, well, Nimmi, while we're waiting for questions to come in, one that occurs to me, and we mentioned up top that you've spun off several commercial entities to try to commercialize the products that you've worked on for years. And while you highlighted in your talk the sort of design thinking that comes from the user interactions, I'm curious how the commercialization piece plays into your design and how you're thinking about, designing a technology that ultimately has to be taken up in low resource settings.
Yeah, a lot of it has happened organically because, we obviously had no experience with this. And I will say that initially, when we started this program and we were funded by the NIH, we were able to do a lot of iterations and implementations at Duke. So we really had an opportunity to pressure test in different countries with different providers and different settings. And, we had what you would say works like. Then it became important that we had to find a way while we were essentially building up the knowledge and experience on the implementation of the pocket, both on the technology level, but also at the systems level. We then had to think about um, commercializing for a number of reasons. One, what you build at Duke is obviously not what is going to go to the provider, because it has to be, a robust product. And sometimes you build things and then at the time of manufacturing, it's not buildable. And we had to work with stakeholders for example, Patty Garcia or others, to figure out what the consumers want in this product, whether they're the providers and NGOs or government. We had to figure out essentially how the product can meet the needs of people. So there was the core technology, but the commercialization really helped us think about the pragmatic issues such as cost of goods, manufacturing. What should it look like? I'll give you just a very simple example. We built the colposcope, and in Peru, the people, the way the size of the hands prevented some of these midwives from actually reaching the button, something as you don't even think about. So the company had the resources and ability to be nimble and address those types of issues that ultimately impact the stakeholders, which we couldn't do as a Duke entity.
Thank you so much, Nimmi. I see Dr. Thomby was the next hand I saw. My apologies if I butchered your name.
Yeah, so first of all, I would like to congratulate the team for making this project a success. So I have just two, three queries from my side. So just wants to understand the age group of the women who underwent the screening. And number two, what I understand from the flow chart is the community health workers were mobilized for getting the screening done from the women. And the community health workers took the HPV self sample, poses in a kiosk. And after I just have a break in between, after disposing in the kiosk, so how was the testing done?
Oh, yes.
In which machine was the testing done? Then I understand the midwives performed the what do you call it? Colposcope procedure and all. Then after that, somebody is getting positive. After they were like referred for the treatment. Just want to understand that break in between after disposing in the kiosk. Where was this testing done and which machine was it used? And I just want to understand the age group also. Whether the target population, like high risk populations, like HIV women, or whether the eligible women were used for screening in this project.
Yeah, just thank you for that question. So I may not answer them in the same order. So in Kenya, it was an HIV, HPV plus population. In Peru, it was just HPV plus. We didn't test for HIV in that population, at least a standard of care. So with respect to the kiosk, what happens is it's basically batch testing like you would do with a PCR machine for, COVID samples. So there's a central facility. that essentially takes all of these samples and does batch testing. And I think the type of HPV test has changed. I believe that Peru's now purchasing cobas. But anyway, that's the base. So there is a gap. So the tests come in, they collect them every week, they test them, and then we send an appointment reminder or schedule an appointment, and then they come in. The age range is within the range that screening recommendation is made. So I don't know at the top of my head, but I think like 25 to 65 might be the age
Yes.
range. And it
Yes.
was probably different. And I don't have that number in front of me, but I'm guessing it was younger patients, skewed towards younger patients in Kisumu, Kenya.
Yeah. Just
Mm,
query that's come into my mind. So just want to understand what will be the cost of this galoscope machine, which is like S-shaped, which will help you in covering the dynamic images and all.
yeah,
What will be
that's
the cost?
Yeah, thanks for asking that. That's still in development. So we just got a grant that's going to allow us to do some larger clinical studies, both in self-use and clinic use capacity. So I would say that that's, one of the technologies in the pipeline that we're still trying to learn more about, and especially get feedback from stakeholders, because the reality is there might be some, one of the challenges we faced in Peru was just acceptance by providers, physicians, of midwives being able to do a procedure that they typically do. And that's understandable, right? They have been trained to do this, and, relegating midwives to do that or delegating them to do that is a question of whether it's safe for the patient, right? So that's why we actually called the exam enhanced VIA. Now, similarly, there are concerns about whether women can do the exams themselves. And that's understandable. It may not be viewed as a very simple technology, and there has to be I think, an RCT of some kind to essentially test whether self-use is feasible and is as effective as in-clinic exams. So I think there's a lot to be done in terms of really establishing its clinical utility. So I would say it's early stage technology.
Great. We have time for one more quick question. The next hand I saw was Dr. Dominguez.
Yes, hi. Thank you for such a great talk. I was just wondering, you started out in Kenya, you had the HIV positive women. I was just wondering, in the algorithm and machine learning sets that you had, were they trained with those that included HIV positive women? And then did they perform as well if you looked at HIV positive women?
Actually, that's a fantastic question because, first of all, the prevalence, so we have this very large data set, right? Well, not very large, but a large data set that was originally used to train the algorithm. The data, the percentage of that data set that's HIV positive is really, really small. So we took some of the Kenya data for that reason and put it in to the training set, and the algorithm did well. But as a complete holdout set, it performed it didn't perform as well. So I think that because we have just started, getting HIV positive patients into our study, I think it's too early to determine what the effect of that will be. And, I've talked to providers, physicians, colposcopists, and what they say is there shouldn't necessarily be any morphological differences or anatomical differences, but it's mostly about the age range at when they present. So that's the assumptions we're going by now, because we have no choice given the small number of HIV patients that are represented in our big data set. So we'll just need to continue to accrue more to really answer that question. But that also speaks to something very important in algorithm development, which is all these confounding variables. And Paul, forgive me if I'm going over, but one thing I want to say is something that we're really thinking about is this is not an exact science. So if you have a user here and a patient and you have a developer here, what needs to happen in between for them to communicate and really understand some of the challenges on both sides? And we're hoping that with these toolboxes, we can sort of create a platform that can allow them to work, collaboratively, because the question you have about HIV patients, right? Someone may not, I know my collaborator in Purdue is not aware of that. And so how do you get people to communicate on the standard, not only the standards, but the factors that could be confounding or be important to the diagnosis of cervical cancer? So I think that what you bring up is an extremely important point.
Thank you so much, Nimmi. We've got a few other good questions in the chat that I'm sorry we weren't able to make it to today. Nimmi, I don't know if there are any quick ones in there that you'd be able to take a look at while we're collecting.
Let's see. Can you read out some to me?
I was just going to say in the chat because I'm being pushed to close the session.
Yeah, I was wondering if you could read some out to me because I can't. Let's see. I can't. Oh, there we go.
All right. Okay, so with that, everyone, that concludes our session today. A very special thank you again to Dr. Ramanujam and all of you for joining us. Don't forget to join us for our next session on October 9th with Miss Nisreen Kadamish. To view and register for the full slate of upcoming webinars, visit our event website at events.cancer.gov/cgh/GCRCSS. Hopefully that's on the slide. To find out more about upcoming events and global health news, visit our website, cancer.gov/globalhealth. As mentioned at the beginning of the seminar, CME credits are now available for the Global Cancer Research and Control Seminar Series. You can claim credits by texting the code to the number on the screen or through the Hopkins CME website. Please remember to set up your account and text the activity code within the next 8 hours. You may want to take a picture of this slide or visit the seminar website at events.cancer.gov/cgh/GCRCSS/education for more details. We'll leave this slide up for another minute so you can have time to capture the information. Thank you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.